So essentially, this exam's kind of got a little bit of everything. My advice to you all, especially for our anti-infectants, like our anti-TB, antifungal, antiviral, antibiotic, I want you guys to have a good understanding of what all antibiotics do and what you need to do for all antibiotics, what you need to know for all tummy meds, what you need to know for all diabetic meds, respiratory meds, etc. So I really want you guys to have a good understanding of just in general what in the world these drugs do. Now, after we get that good understanding, which most of you should have already, we start to look at what I call outliers. What are one or two things that this drug does that no other drug does? What are one or two things that require me to have a nursing intervention or a patient education plan, a PEP, if you will? So, when we talk about specific meds, I really want to focus on the outliers. We're not going to go too into detail for every single med, what it does, why it does it, what it's used for, etc. We're going to look at the outliers, okay? And hopefully my a word about slides will help you guys be successful. If at any point anyone has any questions, you can raise your hand, unmute yourself, pop them in the chat. And finally, at the end of this, I have about 10, 15 practice questions that we can kind of work through together for those that are interested, okay? And if anyone joins later, if you guys can help me out by just admitting them, that would be really helpful on my end, okay? So let's begin. So, a word about antibacterials. All antibiotics are capable of developing resistance. This is what happens when your patient does not take their full dose. So us as nurses, regardless of what antibiotic you're on, you gotta educate, take your full dose as prescribed. You should never stop taking an antibiotic unless you have like a severe anaphylactic reaction, angioedema, facial edema, stridor, all of that, okay? They need to finish their dose. Additionally, what can happen with antibiotics, especially in overuse, is we can have some opportunistic infections and we can have some super infections. So we all have bacteria in our bodies. We give our patient a very broad spectrum antibiotic. There's a good chance that it's also going to take a little bit of my natural biome with it. So what happens when I get rid of some of my natural bacteria? It can cause some other bacteria or fungi or anything like that to kind of run rampant, because essentially they have all this free real estate going on and they're so happy about that. So we're also going to teach our patients about things like oral thrush, C. diff, and what they can do. A lot of it's just going to be good oral care. You know, we can give some antifungals, etc., but we're going to assess for some super infections. Like we already talked about oral thrush, yeast infections, etc. Big issue is severe allergic reactions, okay? We really need to be making sure that if my patient is allergic to one med, that they're not also going to be allergic to its sibling med, if you will. And there are just some medications that require us to pre-treat with some Benadryl, okay? Some meds require peaks and troughs. This helps us stay within therapeutic range. We really do lots of peaks and troughs for our heavy hitter antibiotics. Like if you got an infection, you don't know what it is, you give them this antibiotic, there's a good chance that that infection will be gone. On the downside, more at risk for a super infection. And in our kidney care lecture, we talked a lot about heavy hitters. What really trashes the kidneys? NSAIDs and antibiotics. Okay, so please keep that in mind while your patient's on any antibiotic. We're really going to be looking at their kidney function. Okay. And finally, all antibiotics require a culture and sensitivity test prior to starting any medication. Even if I have no idea what in the world your infection is, if I look at your white blood cell count and it's really, really high, I know you got some sort of infection going on. I'm going to get a culture and sensitivity, going to do a pan culture, and then we'll start you on some antibiotics. Even if we don't know what the exact infection is, we can put you on a broad spectrum antibiotic and then we can narrow it down, okay? But please be prepared to understand how to read a culture and sensitivity test, because this really helps us as nurses determine what antibiotics are going to be best for our patients. So now we're really going to focus on some prototypes. Now, what do I want to focus on with prototypes? What are our outliers? Okay, what are our little pieces of pizzazz, if you will, that occur with this antibiotic and not another type of antibiotic? This is most likely what's going to be tested upon, okay? So first thing we're going to talk about is our penicillins, okay? Keep in mind, penicillins throughout the ages have increased resistance. So a lot of infections can be penicillin resistant. If that's the case, we can actually pair them with a beta lactamase inhibitor to help with resistance. Penicillins are very common. They've kind of were the first ever antibiotics, so they're a good prototype for general antibiotics, such as superinfection, signs of anaphylactic shock, hypersensitivity reaction, etc. One thing to note, though, is that with penicillins, while they're very good antibiotics, it's really common to have a penicillin allergy, and then that's okay, but we need to make sure that if my patient has a penicillin allergy, we're not giving him penicillins, but we're also not going to give him cephalosporins, because there's a very big risk there's going to be a cross reaction, okay? They're kind of sisters, if you will. They're sister meds, okay? Also can be kind of harsh on the tummy, so take these meds with food. Now we have the sister med, our cephalosporins, okay? I like to call them Seth the Giant, and they've got some pretty nasty side effects. Um, we can see some increases in glucose. They're pretty nephrotoxic, and they can actually cause thrombocytopenia. That's like the T in giant, okay? So really, if my patient is on a cephalosporin, I really want to make sure that I'm watching their platelet counts. I'm watching their red blood cells. I'm watching all of that, because we know that these medications can kind of interfere with that. Additionally, when you are on a cephalosporin, absolutely no alcohol. This can cause a disulfiram-like reaction, where essentially these patients look really drunk really, really fast. Dizzy, headache, flushing, not very, very not good for these patients. Okay. And you'll kind of notice that theme. Lots of antibiotics. We don't want alcohol. Up next, we have our macrolides. These usually end in our micins, or MICIN. But essentially, what our macrolides do is they are really good infection fighters. But unfortunately, we want to consider the heart when we're considering macrolides, because these can really cause some EKG changes. And why they cause EKG changes, they just mess with lots of different things, and like to irritate the heart a little bit, okay? This is why a patient cannot be on multiple macrolides. Additionally, if your patient is on warfarin, this can interfere with that. And with our macrolides, no myasthenia gravis, okay? It can exacerbate that further. Additionally, we'll talk about antacids a bit more in the GI portion, but we take antacids alone. Totally interferes with absorption. And if my patient has an infection, I need to get that infection kind of controlled and on its way out, to help keep my patient healthy. So just please keep that in mind. Up next, we have vancomycin. I was going to put a little meme in here, but I can always pop it in your chat. But if anyone remembers the honey badger meme where it's like, honey badger don't care, it just takes what it wants. Vancomycin don't care. It is a very, very awesome antibiotic, very powerful, will get rid of almost anything you got. Very, very broad spectrum antibiotic. However, kind of the more good the antibiotic, the more severe it can also be. So with vancomycin, we have this oddity or outlier, is this red man syndrome. So if someone develops this red petechiae on the trunk, on the arms, on the face, we need to stop the infusion. This is what happens if I give vancomycin too fast. Okay, we don't bolus vanco. We don't give vanco over an hour. We give it over an extended period of time to avoid red man syndrome. Okay, so please, please, please just keep that in mind. This drug is also ototoxic, so please watch your hearing. Vancomycin don't care, it's going to ruin everything else too, but at least you'll be free of infection. So that's kind of some things doctors have to weigh, if you will. Up next, we have our tetracyclines. These are really good for some of our odd, rare pathologies like Lyme disease, a couple of our STIs. Again, very good drug, but also a very, very harsh drug. Our issues with tetracyclines is you cannot be pregnant, you cannot be breastfeeding, and you cannot give this to a child. The reason is this drug can actually interfere with our bone and teeth growth, if you will, and the production of enamel. So if you give this drug to someone that's a child or is kind of involved in that child process, it can really stunt their growth and have some pretty bad effects. Additionally, our tetracyclines are not very, they really should be taken on their own with no stuff. But doxycycline is more commonly used, and it's a lot more safer of the tetracycline group, and you can take that with food and milk, just in case you were wondering. But with our tetracyclines, after they take this, they need to remain upright. If they don't remain upright, it can actually dissolve in the esophagus and cause a lot of damage. Because again, it's a very harsh drug. It's ototoxic, hepatotoxic, and nephrotoxic, okay? So what are we doing? We're monitoring their kidney and their liver function. Do they look jaundiced? Has their urinary output suddenly decreased? Is their creatinine, it was 1, but now it's 5? Those are some things that we as nurses need to be aware when we're giving these meds, okay? Up next, we have gentamicin, our aminoglycoside. Again, ototoxic, nephrotoxic, and neurotoxic, okay? Really, really harsh drug. So what are we as nurses doing with a patient who is on an aminoglycoside? We're monitoring those things, okay? Does ototoxic, nephrotoxic, and neurotoxic sound good? Absolutely not. It sounds horrible. Therefore, we got to be looking at our peaks and troughs, okay? We want to make sure that they have enough in their system to fight the infection, but not enough to essentially poison them and have very, very adverse effects, okay? A lot of people ask, neurotoxic, what are we looking for? Look at their respiratory rate, okay? Remember, our respiratory control centers in the brain. It's kind of back here. So, watch that respiratory rate, okay? Up next, we have our sulfonamides, our sulfa drugs. We've talked about in our UTI lecture about Bactrim Septra. Really, really good drug to get rid of UTIs, but it's got 2 issues, if you will, okay? It can cause photosensitivity, so practice safe sun. These patients might go outside for 5 minutes and burn really bad, so wearing a hat, lots of sunscreen, long sleeves, things like that, really important. Additionally, sulfonamides, they can crystallize in the urine and cause a lot of pain. So what are we going to do to kind of help prevent them crystallizing in the kidneys and making some like kidney stones? We're going to teach these patients to drink lots and lots and lots of water, okay? That way they can keep the concentration low, they can flush it out, and we won't have kidney issues. Because what happens if we have a kidney stone? Fluid backs up into the kidneys and we damage the kidneys, and that's not good. Okay. Up next, we have our fluoroquins, okay? Fluoroquins, love them, but hate them. Why do I hate them? They can rupture your tendons. And if you thought everything else was bad, that's not good either. So if you're taking care of a patient who's on a fluoroquine, keep in mind these will end in fluoxetine. If you're caring for a patient on a fluoroquine, we really, really, really need to do good musculoskeletal assessments on them. If your patient all of a sudden is saying, man, My foot really hurts. What am I thinking? Oh no, that's where their Achilles heel is. That's where a tendon is. Now I gotta call the provider. If they're having some wrist pain issues like grabbing their like cup, we need to start kind of digging into that a little bit more. Additionally, these ones also can concentrate in the urine. So what do we do to prevent discomfort? We flush with water. Okay. Additionally, we can have some dysrhythmias. So really think tendons to the floor with our fluoroquinolones. And now we get to talk about our super fun anti-tubercular drugs. Again, understand big picture of all anti-tubercular drugs. Really, really, really harsh on the liver. Therefore, we're going to avoid alcohol. Why do we avoid alcohol? Alcohol is really, really, really harsh on the liver. So we're not trying to put my patient in liver failure, okay? We're trying to get rid of their tuberculosis. And that's what these drugs do. Our goal is to get negative sputum cultures. That's why we need 90% adherence. Take it as prescribed. And they'll be taking all 3 of these meds probably for a few months, okay? Again, does kind of depend on the patient, if you will. Okay. What we're going to focus on is we have our RIPEs. And that's kind of like what I call TB drugs. You have your rifampin, your isoniazid, your pyrazidamine, and your ethambutol. Ripe, like the banana. There are 1 or 2 oddities in each of these ripe drugs that we need to focus on. Okay. So let's start with our isoniazid. Yes, we know it is an anti-tubercular drug, so we know it's used for tuberculosis and we know it's harsh on the liver. But what is weird about isoniazid? It can cause peripheral neuropathy. So we're going to do frequent assessments, especially on our patient's feet. When you're going down and you're checking their pedal pulse, you're not just looking for a pulse. Ask your patient, hey, can you feel this okay? Or a lot of patients with peripheral neuropathy, they'll be kind of up and walking and they'll be very slow and kind of shuffle a little bit because they just can't feel their feet. What are we going to do to help with this? Vitamin B6. But please, please, please avoid tyramine foods. That's your charcuterie board. Your wines, aged deli meats, cheeses, sardines, anchovies, all of that stuff. Up next, we have ethambutol. When you think ethambutol, I want you to think E for eyes. This can cause optic neuritis. Therefore, we as nurses are going to be educating our patient to take some frequent eye exams, okay? Up next, we have rifampin. I highlighted it in orange to kind of help think orange. Why do I think orange with rifampin? It can turn your body secretion orange, your sweat, your tears, your mucous membranes, all that stuff. So if your TB patient gets put on their meds and they rush into the ER and they're like, I'm turning orange, it's okay. You're going to be okay. This is a normal side effect of rifampin, okay? Please, please, please keep taking your drugs, okay? What can help? Water. And finally, we have pyrazinamide, okay? Really, the issue with pyrazinamide is that it increases the production of uric acid. I know we haven't talked too much about gout yet, but what happens with gout? We have buildup of uric acid that crystallizes, and it likes to crystallize in the joints and under the skin. That's why if your patient has gout, their pyrazinamide might make it a little bit worse, okay? What are we going to do? We're going to drink lots and lots of water, okay? Why? It's to help kind of get rid of that uric acid that builds up with the gout, okay? And pretty photosensitive, so practice safe sun. A word about antifungals. These will only treat fungal infections such as athlete's foot, I think ringworm, tinea capita, candida. So if your patient has a bacterial infection, this ain't going to help. That's why it's also really important to know how to interpret your culture and sensitivity test. However, our our antifungals can, a big complication is infusion reaction with antifungals. However, your patient still needs this. So we want to be looking for any outstanding orders that might give us some information on what we can do before giving this med to help reduce the risk of an infusion reaction. So our AMP-B is our Pauline. Amphotericin B can have some pretty harsh side effects, including really messes with some of our electrolytes, our lights, if you will. Can cause hypokalemia, hypomagnesemia, and metabolic acidosis. Additionally, with AMP-B, you can have this administrating reaction that can kind of mess with their vital signs. They might become hypotensive, things like that. Therefore, if you're on AMP-B, know that it's a fungal drug, but also look for some orders because fungal drugs can have some pretty bad transfusion issues. So usually we do pre-treat with some like Benadryl. That's what your diphenhydramine is. Additionally, this can cause us to pee a lot. And this also can kind of be what's causing our issues with our electrolyte imbalances, okay? A lot more common are azoles, such as fluconazole. These are a little bit more safer, okay? Really, our main issues are some potassium imbalances. They make you pretty photosensitive, and absolutely please no alcohol or grapefruit juice. Okay? Grapefruit juice contraindicated in so many different medications. I don't even know why they sell it anymore. Grapefruit juice and cranberry juice actually are very bad for elders, not because the juice itself is like unhealthy or anything of the sorts. It's because what do we know about our geriatric population? Polypharmacy. They're on lots of meds, and we know that our grapefruit juice and some cranberry juice interfere with lots of medications. Cranberry juice more interferes with some cardiac stuff. But the more you know. So now we're going to talk about HIV and AIDS-related drugs. So we had our lecture about HIV. Really, our whole goal of treatment, we're not curing it, but we're trying to reduce the viral load and keep my patient's CD4 count high. What in the world does my CD4 count does? They are my infection fighters. So what happens if HIV progresses to AIDS, the CD4 count becomes so low that they can no longer fight infection. And unfortunately, that's usually how they die from like the flu or pneumonia or things like that. Additionally, we have PEP versus PrEP. We have pre-exposure prophylaxis and post-exposure prophylaxis. Our pre-exposure requires frequent HIV status monitoring because if you become HIV positive while on PrEP, you have to stop your PrEP. Okay. Additionally, post-exposure prophylaxis is kind of composed of some antiretrovirals. What in the world are our antiretrovirals, or our ARTs or CARTs? These are our NRTIs, okay? One thing to note about our NRTIs is they can mess with our CBCs and our liver function. So us as nurses, we need to do complete LFTs. That's going to be your ALT, AST, and LDL. And we also need to be looking at our hemoglobin, hematocrit, and granulocytes because it can cause a low red blood cell count. Okay. Additionally, can turn your urine dark. Dark urine actually is, in this case, will let me know their liver not doing too hot. Okay. So, a word about our GI drugs, usually classified into antiemetics, laxatives, antidiarrheals, and anti-ulcer drugs. Just please be aware with our tummy meds, a lot of them have multiple different cool functions. Now, we haven't learned too much about GERD yet or peptic ulcer disease yet, But a lot of these drugs can kind of be used for a variety of different things. Keep in mind that some meds that help, improve bowel function and kind of speed up that metabolism naturally have an antiemetic effect. Why is that? Well, it's just because the food gets to move a lot quicker through the body. So these patients won't really feel nauseous or won't have some reflux, okay? But regardless, when we're doing a GI med, we need to be listening to bowel sounds, palpating the abdomen. We need to ask your patient, when's the last time you pooped? How was it for you? What color was it? Was it difficult? Was it your normal? That's a great way to start. Just ask, was it normal? And that will open up a door to responses from your patient, but it's really important. Um, and then, especially with our laxatives, got to drink lots of water. Okay. Not only can laxatives make you dehydrated, but if we give lots of laxatives with insufficient fluid intake, it can cause a small bowel obstruction. Now, how do we know if my patient has a small bowel obstruction? Not pooping, and we're not going to hear anything past the point of obstruction. That's why we got to be listening to all four quadrants. Okay. And then with our anti-ulcer drugs, some reduce the production of acid, some neutralize the acid, and others just coat the ulcers. Okay. But they all help us with the ulcers. So without further ado, begin. Up first is our phenothiazine phenergen. These help with nausea and vomiting. But a big side effect is our anticholinergic dries. Additionally, we need to be looking for some extrapyramidal symptoms, such as tardive dyskinesia, akathisia. If your patient just starts to have any abnormal movements, usually you'll start seeing them in the face, abnormal twitching, they're sucking on their lips, smacking their tongue, things like that. Just know that they might need to be switched to another medication. Additionally, it can alter the color of your excretions, okay? So really watching for those things. Up next, we have metoclopramide. This is a pro-motility drug. It can be used to help with GERD symptoms, and it also helps with constipation because it just moves things along a little bit quicker. It's pro-motility. However, we're really doing frequent neuroassessments on these patients because we can have what's called neuroleptic malignant syndrome, okay? So please, please, please assess your heart rate and your level of consciousness. Additionally, we take these medications before meals. Up next, we have our osmotic laxative, also known as milk of mag. Remember, mag? It's a cation, okay? You look on the periodic table, magnesium's on the periodic table. So keep in mind, remember we talked a lot about kidneys. Patients with kidney issues can't excrete our periodic table of elements. So this is why we're going to watch some kidney function, okay? However, again, magnesium. So what if my patient's mag levels are really, really high? We gotta hold this drug, okay? Why do we hold this drug? We don't want heart block. We don't want cardiac dysrhythmias. We don't want anything like that. Additionally, not sure if you learned about hepatic encephalopathy, but this is a good drug of choice for that because it helps get rid of ammonia via the poop. This is not safe for long-term use. Most of our GI drugs aren't very safe for long-term use. Okay. Up next, we have Ducalax, which is a stimulant laxative. Keep in mind, it takes time to work. Please be familiar what route is the slowest and what route's the fastest, okay? Oral GI meds probably going to take a little bit of time to work. Rectal suppositories work in like 15 minutes, okay? So that's something you as the nurse kind of need to advocate for your patient. Do they need this now? Do they need this soon? Kind of what's going on, okay? Again, we don't want frequent use because your body tells you when you gotta go. by using a laxative or using something else, we've kind of disturbed that mind to body connection. So with overuse, it can decrease the tone and sensation in the large intestine. So we might have chronic constipation and chronic issues using the restroom, and that's not good. Up next, we have one of the only drugs that is safe for long-term use, Metamucil. You might have seen it on the commercials. It's in a little orange box. It tastes like Ting. It is safe for daily use, especially in our geriatrics. They need a little help going to the bathroom. You know what I mean? So with Metamucil, really teaching our patient that it is safe for everyday use, but if you are going to take this every single day, which they probably will, you have to drink lots of water, which is another thing our geriatric population just doesn't like to do, but they have to drink water. If they're taking this with insufficient fluids, we're going to have a small bowel obstruction, and then we have a bigger problem. So they need to take it with water before, and they need to chug some water after. Okay? Not gonna work right away, but that's why these older adults will take it. It helps get them on a bowel schedule. Up next, we have our DocuSate. It's most common in an enema form, if you will. But just know that with our DocuSate, we really need to be assessing for signs and symptoms of dehydration, okay? Can be a little bit uncomfortable. Please review your enema administration, what you can do if your patient's having a lot of pain, a lot of cramping with an enema, things you want to look at before giving an enema, all the above. And up next, we have our anti-diarrheal. So we talked a lot about laxatives before. Well, what happens if your patient has the flip side? They have lots and lots of diarrhea. Maybe it was caused by laxative overuse. Maybe these patients have like Crohn's or something like that, where it's just frequent, and for their comfort and stuff, you need to give an anti-diarrheal. And they're really, really great, but a big adverse effect is toxic megacolon. That's why we got to be looking at our bowel sounds. Look for a rigid board-like abdomen. That can indicate a perforation. Okay. Now, I have a question for you guys. What situations would we want to hold an anti-diarrheal? So when would we not want to give someone an anti-diarrheal? What do you guys think? You can pop it in the chat. When would we hold an anti-diarrheal? And this kind of goes into what we learned about a little bit earlier today. Absolutely. If they've got a tummy infection, we're going to want to hold the anti-diarrheal. Okay. Why do we hold it? Well, if they have a viral infection in their stomach or bacterial infection, or they just ate raw undercooked stuff, the body's way of ridding that infection is by pooping it out, usually making the patient have lots and lots of diarrhea. That's when we would hold it. Why? We want to get it out. Okay. We actually would give an anti-diarrheal if my patient was dehydrated. Because if you think about it, diarrhea dehydrates you. Okay. So if our patient's also on anti-diarrheal, we're assessing how much they've kind of lost. And these patients can lose about 20 pounds, okay? They get massive fluid shifts, massive fluid and electrolyte imbalances. So we're also making sure, they might be on seizure precautions if they're having some sodium issues, potassium issues, probably putting them on telemetry, things like that, okay? But very good job. Up next, now we're kind of getting in our ulcer stuff. So we have our PPIs, proton pump inhibitors, also known as our prazoles. These are really good for GERD and peptic ulcer disease because they help decrease the production of gastric acid. That is what irritates and erodes kind of the stomach lining of not only our stomach, but like the GI tract itself, and that can cause some ulcerations. Additionally, H. pylori infections have to be treated with 2 antibiotics and a proton pump inhibitor. So, really good drug. However, we should not be using this long term because it can put you at risk for gastric cancer. It does interfere with calcium absorption. It will decrease our body's calcium absorption, putting them at risk for hip fractures, osteoporosis, etc. So we're really going to educate on the importance of a good diet, okay, to try to help prevent that, okay? Up next, we have our antacids. Know that our aluminum antacids can cause some constipation, but our magnesium antacids can cause a little bit of diarrhea. Why does that make sense? Well, what does milk of mag do? It's a laxative, okay? But a big thing I want us to understand about antacids is you take antacids on their own. You take them an hour before or after meds. Most meds, oral meds, where do they go? They go into the stomach. What helps dissolve them? Well, the acids of the stomach. As the stomach churns, it sends it through the intestines. They go through the intestinal wall, into the bloodstream, go out to the body, all that great stuff. Well, what happens if I give an antacid at the same time I'm giving my meds? It's going to interfere with the absorption of the med. So my med might be completely useless. And what if they have an infection or they need their cardiac meds? Big, big issue. Additionally, we want lots of water. Up next, we have our cytoprotectant drugs, which is sucralfate. Sucralfate doesn't do anything to the acid. What does it do? It helps coat and protect the ulcers to prevent further damage. However, a big issue is constipation, so we're going to monitor for that. And we take this drug before meals on an empty stomach. That way it can get down there, it can get to the ulcers, it can coat them, it can cover them, it can protect them, so that when we start putting some other stuff in them, they're going to be just dandy. Now we've gotten to our respiratory portion of our review. So, just a word about the upper respiratory respiratory system. It is our nose, mouth, and throat. So, like our common cold, runny nose, things like that can cause lots of discomfort and issues with the students. So, please keep that in mind. Our whole goal is to kind of decrease swelling and congestion because this is our airway, okay? This is where we breathe. So let's begin. Up first are going to be our antihistamines. Antihistamines really good at helping reduce some swelling, helping reduce congestion, all of the sorts. But what do we need to know about antihistamines? They have a really big sedating effect. So not going to operate heavy machinery on an antihistamine. I am not going to drink alcohol because that interferes with sedation. I'm not going to give an antihistamine to a patient who has central nervous system depression because I won't know if they're getting worse. If I have a car accident victim who has increased intracranial pressure, not giving them antihistamine because it's going to sedate them. If I have a TBI and now all of a sudden my patient is sedating, I think my brain is swelling and things are going to get really, really bad really, really fast. So please, please, please know that antihistamines can cause CNS depression and we need to be careful. Additionally, these have our anticholinergic dries because that's kind of what they do. So dry mouth, urinary retention, constipation. Teach our patients, you might want to suck on some sugar-free gum, some ice chips, things like that, okay? And increase fluids. Up next, we have our decongestants. So what in the world are our decongestants? It's kind of like what we use, like Mucinex is a decongestant, things like that. A big issue with our decongestants, though, is they're for short-term use only. My patient should not be taking this long-term. Why? Let's say they took it for 3 weeks, they stopped taking it, and all of a sudden they have a really, really bad runny nose. They have rebound nasal congestion, okay? So it's not for long-term use. not more than 5 days. Okay. Additionally, it can cause some like heart issues. So please watch if you're, especially if your patient's on some antihypertensive or is on some epinephrine, this can kind of make that worse. So think about the heart. Up next, we have our intranasal corticosteroids, which are anti-inflammatories that can be used to quote unquote decrease the action of the nose. Helps reduce swelling in the nose, reduce irritation, especially when we have seasonal allergies, things like that. Just overall reducing stuff that's happening in the nose. However, it is a steroid. What do we know about steroids? Puts you at risk for Cushing's, increases your blood sugar, gives you that buffalo moon hump. You have glucose intolerance, you have edema, um, increased risk of infection. So even though it's an intranasal corticosteroid, what do we know about corticosteroids? Okay. Additionally, this can interfere with some calcium absorption. So we want to increase our calcium containing foods. We also need to know that it can suppress the immune system. And a big side effect is a hoarse voice, which is odd. Up next, we have antitussives. These are our cough suppressants. Please note that we cannot be on an MAOI with a cough suppressant, but these are very, very common. Cough syrup. Okay, so a big thing us as nurses need to be doing is if we're sending our patient home on an antitussive, especially if it's like a mom for her kids, we need to make sure that they're measuring the appropriate dose with an appropriate medication spoon, that they're not taking their household tablespoon and giving it to their kid like that, because it might not be the right dose. Up next, we have expectorants, and these help get mucus out. Okay. However, it can have a little bit of a sedating effect. So, like we talked about earlier, what are our concerns about sedation? Okay. How do we know if this medication is working? Frequently auscultating their lung fields. I want to hear those crackles, those rhonchi. I want to hear all of that go away. I want to hear you sound a little bit better when I listen to you. So with the expectorants, that's something we are going to be watching, okay? So that was a lot of our upper. Now let's talk about the lower, okay? What's our lower respiratory tract? Think our lungs, bronchi, trachea, all that advanced airway stuff. Okay. So, big nursing considerations is knowing when to give these meds. Okay. When do I give one versus the other? So, first, we're going to talk about our short acting beta agonist, our SABA, our salmeterol. We talked a lot about this in Complex Health 1, but to reiterate, this is short acting, meaning it acts very fast. It helps open up the airway, okay? Unfortunately, it can cause an increase in increase in heart rate, blood pressure, and can cause some dysrhythmias, okay? Big thing with this is knowing that we have to give this first. If I have this followed by another med, well, this is my rescue inhaler. I need to open up the airway first, take care of that, and then I can give the other meds. We also need to frequently do peak flow readings. Patients might require a spacer, and please rinse your mouth after using it. Up next, we have our anticholinergics, also known as our our tiotropium, Spiriva. What have we talked about all semester? The anticholinergic dries. Can't see, can't pee, can't spit, can't poop. Okay, those are our dries. What are we going to do for those dries? Increase your fluids, your fibers, and your fruits. Big patient education. This is not a rescue inhaler. This is what we take every day to kind of help, symptom management on the day-to-day basis. But if you are having an emergency, this med's not going to help you. You need your SABA, your short-acting beta agonist, your albuterol. Up Up next, we have our methylxanthines. These are related to caffeine. Therefore, what happens if you have a quad shaken espresso or something like that? You get a little jittery, you'll get a little bit crazy, you get a little bit restless. Therefore, when you're on a methylxanthine, we want to avoid, some more of our stimulating stuff, such as caffeines, energy drinks, dark chocolates, just to prevent toxicity, which can lead to seizures. Okay. Keep in mind, any dose, I believe, over than 20 is considered toxic. Okay. Up next, we have our systemic corticosteroids. So these really, really good with asthma, but it's got some really bad side effects. As you can see, we talked a little bit about general steroid considerations, but with our systemic ones, you can see more body effects. You can see some pulmonary edema, thrombocytopenia purpura, increased ICP, lots of really bad side effects. So please keep that in mind. Additionally, when your patient is on a corticosteroid and let's say it's time for them to stop, we have to taper. You can't just take a systemic corticosteroid or any corticosteroid for the matter and all of a sudden abruptly stop. It can lead to Cushing's. So please, please, please go ahead and review your Cushing syndrome. So now moving from the respiratory, we get to talk about some thyroid stuff. So really, please review your hypothyroidism versus your hyperthyroidism from pathophysiology. This will help you make connections with the medications. Hypo, think low and slow. Hyper, think running on the treadmill at 100 miles an hour. So what does levothyroxine sodium do? Also known as Synthroid. This is our artificial thyroid hormones. What do our thyroid hormones do? They give us energy, which is great for patients that have hypothyroidism. But it's really, really important we be assessing for too much meds. This can lead to thyroxetosis. They can have massive chest pain, insomnia, heat intolerance, tachycardia. They're just going and going and going and going and going. Therefore, we gotta watch for those signs and symptoms and frequently monitor your TSH levels. Okay. Because it can also increase your bowel movements. We might actually opt for a low fiber diet to help hold on to the stool, if you kind of get where I'm going. Up next, we have our PTUs. These are used for hyperthyroidism. So if my patient has too much of T3 and T4, which remember are our energy hormones. So if my patient has signs and symptoms of hyperthyroidism, they've been diagnosed, we looked at their labs, and they're having this massive tachycardia, heat intolerance, weight loss, they're probably going to be put on PTU. However, a big issue is a granulocytosis, so please watch your CBC. Also can be pretty darn hepatotoxic. So monitor for signs and symptoms of liver failure, but please review your agranulocytosis. So I think this is the last topic we have, but this is going to be our anti-diabetics. Please review proper insulin administration, where to give it, what type of tissue you need to give it in, how you give it. Remember, we insert air into your NPH. You insert air into your regular insulin, you draw up the regular insulin, and then you draw up the NPH insulin. Okay? Additionally, please review your Somogyi effect versus your Dawn phenomenon. Remember, with our Somogyi effect, we have a brief dip into hypoglycemia early in the morning, which causes my body to compensate by producing more sugar, which will then in turn make me hyperglycemic. The Dawn phenomenon, on the other hand, that just means my patient maybe needed a little bit more meds because it didn't really take them through the night, if that makes sense. So it rose like the sun. Okay. Additionally, please know your signs and symptoms of hypoglycemia versus hyperglycemia. And a big thing, I know memorization can be a little bit hard, but with our insulin, we need to have a general understanding of when these drugs have an onset and when they peak. Why do I care about when they peak? Well, when these drugs peak, that's the biggest risk for a hypoglycemic event, meaning very low blood sugar, meaning coma, and that's not good. Additionally, how in the world do we store insulin? We can store it in the fridge with the needles upright away from the sun and the heat. So please review all of those general anti-diabetic stuff. So I kind of like to put a few of them side by side for you guys. With our insulin, we have our rapid acting insulin. So this is our insulin Lispro or Humulog. This works really, really, really fast. Therefore, we need to make sure before we give this med that my patient has eaten or their meal tray is right in front of them, not on the way, not, oh, my family member is stuck in traffic, but they're bringing me some like really good. Well, this works right away. Therefore, very high risk for a hypoglycemic event, especially within that first 30 minutes. Okay. Up next, we have our regular insulin. This can be mixed with intermediate insulin, okay? Really, we only mix our regulars and intermediate. The rest we kind of give on their own, okay? So, with this, just know that we kind of have a peak within our around 2 hour mark, if you will. So, they might need a snack. Up next, we have our intermediate acting insulin. So this kind of takes them throughout the day, if you will. So keep in mind, again, this can be mixed with regular insulin, but please, please, please be aware, again, of those peaks and those onsets. Alrighty. Up next, we have our insulin glargine, also known as our Lantus, our long-acting insulin. This really doesn't have a peak. Therefore, no risk for hypoglycemic events. Again, kind of takes them throughout the day. Does anyone remember what is the only insulin that can be put in an IV? Does anyone remember that? It's really important when we get into complex health too, and we start having real diabetic emergencies such as diabetic ketoacidosis, hyperosmolar hyperglycemic syndrome, etc. Which insulin can go in an IV? Might be taking it back to fundamentals a little bit, but what insulin can we put in an IV? Very good job, guys. Our regular insulin, okay? It's the only one we can put in the IV. Very good job. Alrighty. Now, moving away from insulin, these drugs also help with diabetes, usually more common in our type 2 diabetics. We have our sulfonylureas, okay? These overall decrease the hepatic glucose production, okay? Therefore, even if a patient eats some sugar, it interferes with the way my body produces glucose, okay? However, can have lots of issues such as leukopenia, anemia, thrombocytopenia, and again, can cause hypoglycemia, okay? This also helps make their patients' bodies more sensitive to insulin, because what is diabetes? It's insulin insensitivity or complete lack of insulin. So this is really good for type 2 diabetes. But no matter what, diet and exercise are really, really the most important. Up next, we have our meglitinides. I'll butcher that till the cows come home. But essentially, this helps stimulate my pancreas to to release a bit more insulin, if you will. We give this 30 minutes before meals and absolutely no alcohol. Okay. Up next, we have metformin, which we talked lots about in our cardiac lecture. But with metformin, kind of lied a little bit to you guys about our heavy hitters. So our antibiotics, our NSAIDs, and our metformin. Okay. But metformin really harsh on the kidneys. That's why after, you know, that's why we hold metformin if my patient's getting contrast dye, because both are really harsh on the kidneys. If your patient is on metformin, that's why it's really important that we know when to hold it. We really teach our patient, please drink lots of water, because we're trying to help flush it out a little bit. Please watch your pH, because this can lead to lactic acidosis. Up next, we have our alpha glucosidase inhibitors. Essentially, this helps a little bit break down some more carbs. However, it can really cause some liver dysfunction. Therefore, watch your livers, and if your patient is on kind of a good rule of thumb is if they're on 2 oral anti-diabetics, we really need to be careful about their sugars, because you might have to hold it. You know, your patient had a sulfonylurea earlier in the day and it's lunchtime and you look at their sugar and maybe it's like 65. We're probably going to hold this, okay? Also, please take the time to review what are clinical findings associated with hypoglycemia. Okay? So, we finally got into our practice question portion of the review. Please. I love it when you guys participate, and it makes it move a little bit faster, and kind of helps me see your guys' thought process, if you will. So, please participate. And if you don't know the answer, that's completely fine. Put what you might think it is, okay? Because if this were an exam, you're not just going to leave something blank. Or if you've narrowed it down to 2 and you just can't figure it out, put B or D, just let me know. So, let's begin. The nurse is caring for a patient who becomes severely nauseated during chemotherapy. What intervention is most appropriate? What shall we do? Very good job, guys. We give antiemetics 30 to 60 minutes before chemotherapy. Okay? Awesome job. I have another one. You know, your tuberculosis patient's sweat and urine is orange. You reassure the patient and educate him that which medication below is causing this finding. Amazing. Very well done. It is our rifampin. Rifampin can turn those body secretions orange. Therefore, we really need to be doing some good patient education. All right. While monitoring a patient who's receiving intravenous amphotericin B, the nurse will monitor for which adverse effects? what am I monitoring for a patient who is on amphotericin B? What's the nursing intervention associated with amphotericin B or AMP B? What's a good nursing intervention for AMP B? Good job. We have to pre-treat a patient with amphotericin B, usually with some Benadryl. The reason we do that is because of this transfusion reaction. Okay, what will we see with a transfusion reaction? We're going to see some fever and we're going to see some chills. Okay, very well done. Fever and chills is our transfusion reaction. Which statement below is not a true statement about antiretroviral therapy? Awesome job, guys. So the correct answer is D. All of the other ones are true regarding our ART treatment. Remember, ART must be taken exactly as prescribed every single day, even if your patient's signs and symptoms disappear. If not, you can kind of have some issues with your CD4, drug resistance can develop, and it might end up not being effective. So please educate your patient the most on medication adherence. Very, 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 very good job. A patient with active tuberculosis is taking ethambutol. As the nurse, you make it priority to assess the patient's what? What will we assessing on ethambutol? Very good job, guys. We assess their vision. Remember the E in ethambutol, you can think eyes. Why? It can cause optic neuritis. So we're going to be watching their vision. Very good. You suspect your patient will be prescribed I might have reworded this wrong. You suspect your patient will be prescribed an antibiotic for the treatment of an infection and a culture is ordered. What should happen next? Very good job, guys. We have to make sure that we get a culture and sensitivity before starting on an antibiotic. Even if we don't know what the infection is, we can start them on a broad spectrum antibiotic to kind of cover our bases. But you have to get a CNS test before you give any antibiotic, as it can interfere with the results of the culture and sensitivity test. So please review how to read one of those. A nurse teaches a client taking metoclopramide to discontinue the medication immediately and call the physician if what side effect occurs with long-term use. Great job. I see a lot of C's. What is that? If I notice these uncontrolled rhythmic movements, what are those? What are they called? Absolutely, those are our extrapyramidal symptoms, such as our tardive dyskinesia, akathisia, etc. Very good. If your patient develops those, they probably need to be put on another medication. Alrighty, and then this is more of like nursing intervention. Um, if extravasation of an anti-neoplastic medication occurs, what intervention will the nurse perform first? So even if you don't know what the anti-neoplastic medications do, what do you do if you have extravasation? Awesome. You notice that you have fluid leaking into the surrounding tissues from your IV. You stop the infusion. Very good job, guys. Your patient asks how stool softeners relieve constipation. Which of the following would be the best response by the nurse? Stool softeners relieve constipation by. It is going to be C. What do stool softeners do? They help increase water into the stool to help bulken it up, soften it up, and help make it pass a little bit easier. What is our main nursing consideration with stool softeners? What do we have to do? What do we have to educate? Nursing consideration. Awesome. Thank you, Sarah. We got to teach them to drink lots of fluids. We got to make sure that we are not having a small bowel obstruction, which we would be able to assess for by listening to them, palpating them, all the above. Alrighty. Your patient who is receiving pyrazinamide reports stiffness and extreme pain in the right big toe. The site is extremely red, swollen, and warm. You notify the physician, and as the nurse, you anticipate the doctor will order what? What do we think is going on with our patient? Yep, we need to get a uric acid level because we know that pyrazinamide increases the uric acid levels, which worsens gout. That really bad toe pain or joint pain, or even you'll be able to actually see manifestations on the skin when those uric acid crystals build up and deposit places. Alrighty, everyone, last question of the night. A client has been receiving a cephalosporin for 20 days to treat a severe bacterial infection. The client complains of mouth pain, and the nurse assesses white patches in their mouth. What's the highest priority action on the part of the nurse? Bonus points. After we do something, how are we gonna help the patient? What do you think might be in our plan of care? What are some of the next steps? Yep, they statin, swish and spit. They have oral candidiasis or from, super infection. They now have yeast. So the answer was C, notify the physician. And what are they probably going to be included in their follow up? The swish and spit. All right. You guys did very, very good. I'm really impressed with your answers. You guys are really making those big connections. Additionally, if you go on Canvas, I believe your professor, Mr. Frolov, has included more practice questions for you guys to do. Thank you so much. And if anyone has any questions, feel free to ask.